تقولوا لي هو هوب ان انا اقدر اقدم حلول علشان ازاي ما نضطرش نعمل ريلود. يعني actually the hope دلوقتي ان احنا نماكسمايز السنجل بروسيجر اوتكم، ان انا اوصل بالاي اف ابليشن لدرجه ان انا ما احتاجش اعمل ريلود. احنا moving toward this direction. كلام على الديورابل بي في اي we're almost there. الكلام دلوقتي بيتغير ان احنا what to do when there is no PVI connection في الريلود procedure، وازاي ان احنا ناخد الداتا من الريلود procedures اللي ما فيهاش PVI connection ونحاول نابلاي للفيرست index procedure بحيث ان احنا to tackle all the problem from the first go. So this is my case. شكرا للدكتور محمد ابو هديمه لان هو موجود معانا جمع معظم التريسنج بتاعت الحاله. كل التيم اللي كان موجود معايا رنساوي ومحمد والدكتوره غاده كانت موجوده في الحلقه. اوكي الكيس 56 سنه female patient hypertensive history of paroxysmal AF which had VASC score 2 by virtue of hypertension and being a female. في 2006 she already underwent PVI in very good hands in carpet system using carpet system. Okay. بعد الفترة she remained fine for like 3 years and started to have asymptomatic recurrence. السيمبتومز بتاعتها ما كانتش classic palpitations بس كانت more like fatigue. بانت ان هي palpitations كان فيها occasionally refractory to medical treatment. She tried amiodarone, thyroid problem, went on sucralose and ritmone as well, and all of them failed to control her symptoms. Kept on Mariban for Chad VASC score. Echo normal left atrium is not very dilated, and this is her ACG. للوهله الاولى الirregularity تدي impression انه ممكن يكون AF، لكن actually when you look closer at V1 there is some sort of what seems to be an organized atrial activity, atrial tachycardia, atrial flutter. In general, we cannot discriminate atrial tachycardia from atrial flutter and ECG. في criteria كتيرة جدا لكن all of them are not very specific. In particular, after AF ablation you cannot do this بسبب السكارز اللي موجودة في الليفت atrium وبسبب كل حاجة. And if we going to use this criteria هندينا impression this is might be atrial tachycardia due to the presence of visible baseline between P waves. لكن as you will find out this is not the case. After the proper preparation of the patient in the atrial thrombus exclusion by TAE, we took the patient to cath lab and we put our catheter in. The patient, lucky for us, she was in tachycardia on that day. أول ما حطينا ال coronary sinus, distal, proximal, his. As you can see, there is an organized atrial activity with distal to proximal activation in coronary sinus, and for us this could be a potential nightmare in the cath lab. Anyway, the first thing to do قبل ما تعمل ال 3D mapping بتاعنا ان انت use a simple diagnostic test علشان to know what we're dealing with. First step, entrainment. أول حاجة عملناها entrainment from the proximal coronary sinus. As you can see here, pacing faster than the tachycardia cycle length, PPI minus tachycardia cycle length from the proximal coronary sinus أكتر من 30 millisecond indicated that the proximal coronary sinus is outside. At least it was a kind of a relief at that point. It's not typical of perimitral flutter, which is a good news so far. Second, we moved on to entrain from the distal coronary sinus. The activation in distal coronary sinus was in tachycardia, accelerated the pacing cycle length, return at the same cycle length, and the PPI minus tachycardia cycle length was like 20 milliseconds. So the distal coronary sinus was inside the circle. A discrepancy that is not commonly seen مع التيبيكال فلاتر. طيب ايه هي الماكرو انترال تاكيكارديا اللي احنا بنفكر او الانترال تاكيكارديا اللي احنا بنفكر ان احنا نلاقيها في البوست اي ابليشن؟ بريمايترال فلاتر اوف كورس، روف ديبندنت فلاتر possibility, and septal regional flutter whether around the veins or around the scar. And this is the common consensus, and you can go to this reference Wood's book, very famous textbook. So far we have nothing typical. Regional tachycardia maybe is the reason. I quoted this paragraph, and thank you Ahmed for quoting it, and I kept it here لأن أنا عايز أقرأ ال first few lines. Between 20 and 50% of atrial tachycardia that occur after catheter ablation or atrial fibrillation arise from focal origins. the vast majority of these focal tachycardias are thought to be due to small reentrant circuits. A characteristic feature of the localized reentry or micro reentry is, and please pay attention to this, is the presence of low amplitude, long duration, fractionated electrogram that occupy a small region of the atrium. Again, presence of low amplitude, long duration, fractionated electrogram that occupy a small region of the atrium. An activation of the atria proceeds in a centrifugal manner from these. An entrainment of those sites will yield post-pacing interval less than 30 milliseconds. Another characteristic of the arrhythmia is the insensitivity to adenosine and medical treatment. So we have a tachycardia that could be a micro reentrant so far. Okay, we went on, put our catheter in the left atrium, lasso catheter, and the first thing, even before creating that 3D map, is once you put the catheter in the left superior pulmonary vein, we notice this signal. Small, fractionated occasionally, and high frequency signal inside the pulmonary vein. At that point, we didn't know exactly what is this. This could be a far field, near field with a very long delay inside the pulmonary vein, or could be a double potential inside the pulmonary vein. We're not sure of this so far, but this is what we saw in the left superior pulmonary vein. And when we move the catheter, just try to pull it backward towards the STM to get a better contact. This is what we found. Low amplitude, fractionated, and long duration. This is a fractionation that spans almost 50% of the cardiac cycle. Again, this is not necessarily an entry, not necessarily macro entry, could be a delayed conduction due to previous ablation, and could be an entry. However, this is the left superior pulmonary vein, and we had a very short PPI, coronary cycle length from the distal coronary sinus, and in a second I will show you the position of the distal coronary sinus. Unfortunately, by catheter manipulation, before even being able to map it or perform activation map, it seems like a PAC from the coronary sinus, from the outside the atrium, that terminated tachycardia. But lucky for us, if you look at the position of the lasso catheter, look at the signal of the lasso catheter. If I go through the channels, the lowermost channels are the coronary sinus channel up to here from distal to proximal. These are the lasso channels, and these are the ablation channel. Look at the lasso channel here. You can see here, this is the far field atrial signal on the lasso, but there is a late sharp potential, denoting that this is the PV potential. This vein is reconnected. So we try to induce the tachycardia again, but the problems doesn't come except in groups. Could not induce the tachycardia. What to do next? As expected, we went on to create a map of the left atrium in sinus rhythm doing the lasso system. Now, using the NAVIC system. One of the nice things with the even earlier version of the NAVIC system is that you can use the lasso catheter for high density mapping. You can still acquire, it's not automated, but you can still acquire multi-point for all the electrodes on the lasso catheter. No, sharp precision, even velocity.
لا قصدي لاسو ناب.
No, لا أي لاسو كاثر، أي circumferential mapping كاثر. مش لازم على النافيك سيستم، على النافيك سيستم ما بيتطلبش لاسو. We're using the NAVIC system.
نافيك سوري. لا ما دي حلاوته.
Yes. So this is what we found. To look at the maps closely, this is the left inferior. Okay. This is PA view. This is the left inferior. This is the left inferior. As you can see from the previous ablation, it seems almost isolated. The left superior, if you look here, let me go to this map for better visualization. This is the left superior from superior view and anterior view. You can see something similar to the case we presented. The connection almost exactly in the same site. It is again the ridge, okay, and to a lesser extent the carina. And if you can see here, although we ablated this here, still you can appreciate the signal connection in this region. Now, unfortunately, again similar to the case we presented, the right-sided veins are heavily connected. If you can look here from the, this is the right vein, okay, this is the right inferior, very huge islands of reconnected potentials, and the right superior you can appreciate there is significant tissues reconnecting right superior مع left atrial body. So again, the right-sided veins are reconnected exactly similar to what you had in your case. So why do we find this? And this is going to be an insight towards why these sites are common. This is a study from the contact force catheter, and they are measuring the contact at different regions in the left atrium. And this is a nice study. They first blinded the operator to the contact force, and then revealed the forces and allowed him to remanipulate the catheter to see if he can get better contact at the site. And this is what they found. If you look here, this is the ridge, the area where we had connected. This is the lowest contact force, blinded contact force. The first number is the blinded contact, and this is after revealing the contact force. So this is an area that it's commonly, we don't have good contact there. 8, and this is the one of the lowest. If you compare other region, 9, 12, 14, 13, 11, this is by far the lowest. The ridge and the left triangle. So we know that the stability and contact of the catheter at this point is bad. Now, what do we, as I said, this is lessons for maximizing the outcome of the first procedure. Ideally, we would use a contact force catheter here because from this study, it shows that if we spend time and try to get better contact, you can increase the contact. But you need to have a visualization of the contact at that site in order to do that. What to do without contact force? Is there an alternative to maximize? And this just this year, an interesting publication was present in the literature describing what is called the toast lesion, especially for ablating the appendage. And in this approach, you ablate the appendage from both sides, from inside the pulmonary vein and from inside the appendage. And as you can see here, this is the left lateral view, the left superior, the appendage, and this is the ablation catheter pointing towards the ridge from inside the appendage side. And as you can appreciate, there are lesions there delivered from the pulmonary vein side. So this is called a toast lesion in the appendage. The authors presume that the toast lesion technique increases the long-term success of patient ablated for symptomatic paroxysmal atrial fibrillation. And in our countries where resources are always an issue, this could improve the first procedure outcome and minimize the reconnection at these sites. So this is the left inferior pulmonary vein. Again, you can appreciate the late connection there related to the carina. And this is what we saw during the tachycardia. The site, the spot we marked red in the ridge that had very fractionated late potential. So we went on to confirm whether this is a true connection or not. We are pacing from the ablation, from the last catheter, from the electrode where this signal, this potential is seen, and there is exit conduction from that point. So we started ablation. It can see the late potential is getting later. This PV potential is getting later until it disappeared completely, and that spot was isolated. Probably it was pulmonary vein related or gap tachycardia, because if you can see here, this is the distal CS catheter, the one we were inflamed from and had a very close. It is very close to the circuit. Probably this is a micro re-entry related to this gap. Okay. So this is probably a lesion. For this ridge, yes, for this ridge, if you have a contact force sensing catheter, ما عندكش toast lesions. This is my message. Yes,
inside
from them. But this is described. Anyway, it is usually in width, in anatomical studies, ridge width بتاعه كلام maybe 3.5. It's difficult, very difficult to have a stable catheter on the ridge. You end up many times, going inside the vein, pulling the catheter as backward as possible, trying to maintain contact with the ridge and ablate at the point just before the catheter slips out of the vein. Okay? And you can do this. You choose to ablate from inside the vein. Similarly, you can do this from the other side. from the entire diaphragm and try to extract. So this is my first message regarding the connected ridge. So this is exit conduction, demonstrated ablation, potential delaying and disappearing, and this is exit block. And this is actually a nice slide because we don't get often. Many times we describe exit block, but actually you cannot prove that an exit block might be non-captured. And the only proof that you have exit block is that you had a local PV capture. And look at this. Can you look at this? This small potential just after spike that is actually present here. This is local PV potential not conducting to the left atrium. So this is actually a true exit block. Rarely seen, but yes, we've seen it in this case. The left superior pulmonary vein is isolated, again by pacing, and we move on to the right pulmonary vein. Now the problem with right pulmonary vein, I know the operator and I know he was a very skilled, talented ablator of pulmonary veins, and I was kind of surprised to the extent of reconnection with the right pulmonary vein. Now we can do the same thing again. But this is reconnected. 2006 ablated 2006 but was reconnected. But wait. ايه؟ احنا معاك 10 سنين تحديدا.
بس هو ممكن زي ما قلت لك قبل كده مش لازم الريكونكشن it's due to a fault in the operator.
It's not necessary.
Not necessary.
But
ممكن يكون عمل كل حاجة.
the question is, I was a bit skeptical about performing the same thing again. يعني if you do the same thing, you probably get the same reason. Really acute disconnection and this and that. So we were thinking what to do to maximize this. This is what I'm trying. Right veins are reconnected, and we're pacing from there. There is exit conduction. How to achieve a durable PVI with low resources? Let's go to the guideline and see what's there. 2017's ablation, AF ablation guideline, PV isolation by catheter ablation. Look at this one. The use of pace capture along the ablation line may be considered. So this is something is already we have, it doesn't require any more resources, and we can do it. Yes, but I did identify the reconnection. And I said from the last two catheter, we have a reconnection. Okay? I will have to ablate this. But I need to do something better. Ideally, if I have a contact force catheter, I would have used it, but I don't. So I have to use the resources I have. When you look at the literature of pace capture, it's very interesting. This is not a new technique. This has been there since 2010. Yes, and actually, this publication performed pulmonary vein isolation with single catheter, just ablation catheter, using the pace and ablate. So what they did, as you can see, this is ablation, this is coronary sinus. There is no lasso here. They go around the vein with the ablation catheter and 3D mapping system, and they pace. And one of the nice thing about the inside velocity system is this is the system that allows you to pace and ablate. You cannot get this feature on bike. Yes, unfortunately, but it is something there. We use it. It might improve. This is described. And does this actually improve the outcome? Does this allow you to get it durable? Look at this literature, this publication. Interestingly, they repeated this same study. 60 pairs PV, blinded the operator of the elastic signal, and asked them to ablate until loss of pace capture circumferentially around the vein. They achieved that in 57 out of 60, so it's 95%. And in almost half the number, in 53 out of 57, they achieved complete isolation on the elastic catheter even before continuing the circuit. So indicating that they had accurate and they had true lesions by this approach. Again, does this improve the durability? This was tested against adenosine for acute reconnection. And interestingly, the authors of that publication, I didn't present it here, but they claim that we no longer need adenosine because they correlated the use of adenosine with the rate of pace capture, and they found that there are no difference. So you can omit adenosine completely and depend on pace capture technique. And this is another publication when they actually followed up patients after isolation using this technique. And yes, the outcome is better. So when they ablated using a pace capture, it's better. it's not yet studied whether the pace capture entails specific grams, specific contact, because this might be the case, and this is why it works. Because if you have capture, it means that you have reasonable contact at least, but we don't know that so far. This could be a publication for us to do, but it works. So this is what we did. We use a pace capture technique to nail. We are here pacing from the ablation catheter, as you can see, pacing from the ablation catheter, and we only move the catheter when we get loss of pace capture from that point. And this is, we want on like this to complete the circular lesion. Again, loss of pace capture, pacing, capture, and then loss of pace capture until we completed the lesion. Here, as you can see, the PVI disappearing with ablation and completely disappeared, completely isolated, and repeated the same thing for right inferior pulmonary vein. Again, pace, loss of pacing, and until loss of pace capture. And this is what we did. Complete circular ablation, and we had to go through the carina as well to isolate the vein. Hopefully, we achieved something with this. And the patient, I've seen the patient now, it's been 3 months since we did this. And I saw her like last week, and the ECG was perfectly fine. She was in sinus rhythm of antiarrhythmic medications. So we didn't conclude at that point because, as you remember, the patient went in regular cardiac flutter, regional flutter. It was not inducible. So we thought of, after finishing the vein, might be immune effect, we try to induce again. And surprise, surprise, we got another tachycardia. The same, exactly, yes. Another tachycardia with activation sequence from proximal to distal in coronary sinus. The usual stuff, entrainment from proximal coronary sinus, tight, almost inside the circuit, 0. We moved the catheter to lateral CTI, still inside the circuit. So this is CTI dependent. But the story doesn't end there. Went to ablation, and unfortunately we didn't get termination of tachycardia. Why? Look at this. This is the ablation line, the ablation points on the catheter. You can appreciate 2 colors, one of them brown, one of them is yellow. The brown ones are the ones we did in the beginning. So this is the drag point. As you can see, it is in RAO position, it seems like a curve. Okay, this is just the drag points. You get a point in the ventricular end of the CTI, and you drag the catheter until you reach the proximal end. But it didn't terminate the tachycardia. And the reason for this is pouch. It is very common. It's actually more common than we expect. There's some publication estimating the incidence to be almost 40%. So when you do this, after you check your point, if you can find signal, dig deep. And these are the deep points that we had to bend the catheter in the pouch and try to deflect and undeflect to cover all the area. And this is what we got. A termination, a clean termination. And of course, at that point, we used the lasso catheter to put it in the lateral CTI as a marker and ablation. And then we tested pacing from proximal coronary sinus, lateral CTI, transisthmus conduction time is 170. Pacing from the lateral CTI to proximal coronary sinus, this is the lasso catheter, it's 157, again above 140. And pacing from the ablation catheter just lateral to the ablation line, it's longer, so we have a bidirectional block across the line. And this is the final result, sinus rhythm after ablation. So my take-home message is that in similar cases, you need to have a stepwise approach. If you have a map of the stable tachycardia, you need to map it. Entrainment map, as Dr. Mohammed highlighted, is still very important in case of microentrant tachycardia, and turned out to be very useful in this case. If the pulmonary veins are not isolated, then we can have a debate about this. But the way I trained and the way I perform this is that I first isolate the pulmonary vein, even if I have. Could be. I have not seen it. This is not the tachycardia that was at the beginning, but this sustained. يعني لو عملنا كيس بالمنظر ده وجات لنا اسمه dependent tachycardia, would I leave it? I wouldn't. It is stable. It was stable. And this is a new case. So the last thing I want is this patient to come for the 3rd time with isthmus dependent flutter. If I have flutter, I'm not advocating prophylactic CTI at all. But if the flutter is inducible, maintained, and confirmed to be CTI, I think we need to have re-isolate the vein first. Ablate stable atrial or macroentrant tachycardia. Post-ablation testing to detect any inducible tachycardia. And finally, loss of pace capture can be used to achieve durable PVR. Thank you very much.